Well, good afternoon, everyone. I'm Maynard Karkup. I'm president of COPA and chairman of Freedom Innovations. Welcome to my home office. Uh, Everybody on my end has been working remotely, as I'm sure most of you have been. It's a great pleasure to welcome you on behalf of COPA to the webinar today. And from COPA's perspective, we're excited about the opportunity to collaborate with AOPA to provide members an update on federal policy, regulatory issues, and also the COVID-19 public health emergency. It's my honor to introduce our speaker, Joe McTernan, who is the Director of Reimbursement Services, Education and Programming for AOPA. Joe's been with AOPA for about 22 years, and I've had the pleasure of knowing Joe all 22 of those years, as well as probably some of the time when he was Director of Regulatory Affairs for Hanger in Bethesda, Maryland. I can attest to the fact that Joe is the acknowledged expert at AOPA on regulatory and legislative issues. I've attended many AOPA events and many policy forums with him on Capitol Hill. And many of you know that the AOPA Policy Forum, where we would all gather in Washington and we would go up on the Hill to meet with our legislators and their staff and to advocate on behalf of the O&P industry, would normally happen this week. I believe that AOPA, Joe will probably address this, but AOPA has a virtual policy forum that will be held tomorrow, I think 1 o'clock online as a virtual meeting. And so it's 1 o'clock Eastern time. So it's an exciting time for the industry, a lot going on. There's a lot that needs to be done to get the industry on track and hopefully reopened in a broad way shortly. So Joe, thank you very much for making yourself available for this webinar. And I'll turn the meeting over to Joe with just one note that if you have questions, Joe is a very facile presenter. So if you haven't used Zoom before, just look for the chat icon and hit on the chat icon if you have a question. And go ahead and type in your question, and Joe will work it into his responses as appropriate. And then at the end, I'll rejoin the conference to close out the session. So with that, Joe, I'll turn the meeting over to you.
Thank you, Maynard, and thank you, everybody, for spending some time with us today. It is truly an honor to be here to present to you all and to give you hopefully some good information about what AOPA is tracking in regards to the COVID-19 public health emergency and some of the things that have been done in reaction to that emergency by the federal government and what AOPA is following in that process. So without further ado, we do have quite a bit of material to cover in a relatively short amount of time. So just a very quick introductory slide about kind of who we are. AOPA is one of the national trade associations representing O&P on Capitol Hill and in the federal arena. We have over 2,000 patient care facility members and about 150 plus manufacturer research and educational members that we call our quote-unquote our supplier members, our partners in the process. So we hopefully do a fair job of representing everybody's interests on the federal level, and we always look to work with groups such as COPA and other state organizations to make sure that we are all working on issues proactively and collaboratively. So let's talk about things you should know. And today's presentation will really focus on COVID issues, as that is kind of what's at the front of everybody's mind right now. And some of the other things that are on the radar screen that are relative, not necessarily relative to COVID, but have been impacted by COVID are going to be discussed as well. So let's talk about some of the things that you guys want to make sure you're aware of, that I want to make sure you're tracking. So AOPA has tried since the beginning of this public health emergency to kind of give folks a central location as to where to go to get information about COVID-19, about what the resources are, what's out there, what information is out there, and how to access that quickly. So one of the places that we keep a central repository of all that information is on our website. So if you go to the AOPA website, if you go to the resources page, which you can see, if I have my mouse right here, you can see is at the very top right of the banner at the very beginning. That will open up to your drop-down message, and you click on COVID-19 responsive resources, and essentially you have a whole list of all of the things that AOPA has done with regards to getting information about COVID-19 and like out to members, out to the public in general. So it is truly meant to be a one-stop resource where you can go very quickly and learn some information. The other half of that puzzle and the other half of that equation for those of you that were able to join AOPA and COPA last year, I believe, for our last collaborative webinar, are probably familiar with the AOPA co-op. So this is a project that was started about 3 years ago. And Ashley White, my colleague on staff, this is really her bread and butter. But the co-op is basically a one-stop shop where you can get any information you need to get about reimbursement coding and policy within the O&P realm. And one of the things that's really nice about the co-op that we're going to see in just a second is it does have very specific individual state-focused pages. So if you're not familiar with the co-op, if you did not participate in last year's webinar with Ashley, she does several live tutorials on this product at least once or twice a month. The next 2 tutorials that are coming up, and you can actually get continuing education credits for both of these. Excuse me, we have one scheduled for May 15th, and then we have another one scheduled for June 19th. So Ashley has been doing these about once a month. They've been well attended, and folks seem to really enjoy the platform and the way the co-op is set up. What's really nice about it is that you can become involved, especially on the state side of things, and you can become a contributor to the co-op site and provide really good resources to your fellow state members, state association members, and your fellow AOPA members. So this is our State Matters page on the co-op. It's very user-friendly. It's very intuitive. You would literally click on the map. In your case, if you clicked on California, it would pull up information that is relevant in that individual state. Okay. So great resource. It is a member benefit. There is no charge for that if you are an AOPA member. It is part of your AOPA membership dues. Okay, so what do you need to know about COVID, and what do you need to be aware of as far as how you should be, how you might be operating your business during the COVID-19 public health emergency? And one of the biggest and one of the most important questions we get at AOPA literally multiple times a day is, are we essential businesses? Is O&P considered essential? And do we have the right and the ability to stay open and to continue to serve patients? And the answer to that question is a definitive yes. Both O&P patient care facilities and O&P manufacturer facilities companies are both considered essential under the definition of essential businesses as far as healthcare businesses that are continued or that are allowed to continue to operate within the COVID-19 public health emergency. There are exemptions for all essential businesses that exist under any of the state stay-at-home orders, shelter-in-place orders. So there is nothing legally that is preventing any O&P business that we are aware of from continuing to operate, whether it be on the patient care side or whether it be on the manufacturing side. So that's good to know. And Maynard said earlier that the chat box would come in. I don't see it right now, so I'm gonna keep going on, and then I will bring it back up. I think it's because I'm in slideshow mode. I can bring it back up at the end and go through and answer any questions. If there are any questions that any of my colleagues can see that they feel need to be answered, please feel free to chime in, and I'll be happy to respond. Okay. So one of the other big things that has come out of the COVID situation is the obvious need for some form of stimulus, some form of relief to the provider community. This has obviously impacted every single healthcare business in the country. I don't think there's a business out there that is seeing more patients, at least on the AOPA side, that is seeing more patients necessarily than they were seeing before COVID came into play. Maybe on the hospital side of things, unfortunately, but as far as outpatient services particularly have seen a dramatic decrease as quote unquote non-emergent situations have kind of been put on hold and put on the back burner. So one of the first things that's come out of Congress is what is called the CARES Act. The CARES Act is an acronym which stands, I think it's the Coronavirus Access Resource, I have it on my next slide, there it is. I've lost it, I'm sorry about that. But the CARES Act came out of Congress and basically provided $100 billion in earmarked stimulus funds that would be provided directly to the provider community, the Medicare, the healthcare provider community. These are not loans. These are grants, and we'll get to the loans in just another minute with a second program that's been out there. But the CARES Act provider stimulus funds was $100 billion that was set aside in provider stimulus. So $30 billion of that stimulus went out almost immediately, literally within days of passage of the act. Providers started seeing checks or electronic funds transfers show up in their bank account with a description line of HHS stimulus or something along those lines. Okay, that was an automatic distribution that was sent out to every single Medicare enrolled provider who provided services to Medicare patients in 2019. Your portion of that payment was basically determined by what percentage of overall Medicare expenditures your billing represented. And I can give you the very long, drawn-out, complicated equation that was used to get there, but it suffice to say that when AOPA looked at the calculation, looked like it ended up being about 6% of your Medicare billing for 2019 was sent immediately back to you in the form of this stimulus. Okay, there's another $20 billion for a total of $50 billion total that has been set for what is called general distribution. That is distribution that is not earmarked or not dependent on your particular company's caseload for COVID-19 patients. In order to qualify for a portion of that $50 billion, all you have to be involved in is the potential to treat a COVID-19 positive patient. And CMS and HHS have been extremely clear that their interpretation of potential in this case basically says that if you treat a Medicare patient, you can be assumed that every single Medicare patient is a potential COVID-19 patient, and therefore the stimulus would apply. Okay, so the $30 billion was distributed automatically. The $20 billion, access to that is available through an application process, and we'll see a website in just a minute where you can access that additional information. That has to be applied for, and in that application you have to submit very specific revenue information as well as an estimate of your lost revenue specific to your company that will determine what portion of that additional $20 billion will come to you. Again, does not have to be directly related to COVID-19. It's still in the $50 billion pool of general distribution, but it is not an automatic process for that additional $20 billion like the first $30 billion was. Okay, there was an additional $50 billion in targeted distribution that makes up the other half of the $100 billion. That is probably not something that there will be a whole lot of access to for O&P, because that's going to be your mark and reserve, specifically for places like hospitals, et cetera, that are treating very, very specific cases and directly working with patients that are positive for coronavirus. Okay, so I'm going to move this just a little bit so that I can see a little bit better here. Sorry. So the other half of the CARES Act is what are called the PPP loans, or the Paycheck Protection Program loans. And actually, this had to be accomplished through the passage of two bills, first of which was passed March 27th, which initially offered $350 billion, or approximately $350 billion, in mostly forgivable loans that were going to be handed out or processed through the Small Business Administration. That money ran out extremely quickly. Within less than a week's time, that money was exhausted, and folks were getting pretty upset that all of a sudden, because they had not made that application in the first day or two, that they did not have the opportunity to access those loans. So a second bill with an additional $321 billion in loans was passed by Congress late in April, which is probably getting close to the point where that money may be exhausted fairly shortly as well. But all told, you're talking almost $700 billion in small business loans for the healthcare provider community, most of which would be forgivable, assuming that conditions were met. Okay, and the last part of the CARES Act that AOPA was pretty excited about seeing was there was actually specific language built into the act that guaranteed veterans would have the choice of providers should the VA not be able to provide appropriate care through their existing clinics and existing resources. And that was something that AOPA has been working for quite a while, to make sure that veterans do not lose the ability to continue to see providers of their choice within the community. So that was some good information. So a lot of this I've covered already, but again, I want to just go over this again. The $30 billion in initial stimulus that was released as grants, that was sent automatically based on a percentage of your 2019 Medicare payments. And in order to keep that money, yes, you do have to sign a specific attestation statement that is available on the HHS website. Now, the catch here is that if you do not sign that attestation, the default system is that you then, by default, attest to the conditions. So if you don't sign it, they're not going to take the money back. They're just going to assume that you are attesting to the conditions. So this has led to a lot of questions. We've fielded a tremendous amount of questions from AOPA members specifically about this. And the general consensus and everything that we have read, everything that we have heard, everything that we have seen is that should be no existing Medicare healthcare provider that should have any concerns about signing this attestation statement and keeping the money. Yes, it does say that the money is designed to be used to treat either COVID-19 patients or potential COVID-19 patients, but as I said earlier, CMS and HHS have both been very, very clear that they will use the broadest interpretation of that requirement, and that there should not be any concerns. If you have concerns, there is a provider hotline there. The number is on the slide here. It is a provider hotline through United Healthcare, which was used as the conduit for the initial distribution of these funds. So the next bullet that talks about the additional $70 billion, that's the $20 billion in the secondary allotment for general distribution, plus the $50 billion in targeted funds that we talked about earlier. Okay, so moving on quickly to the VA choice language, this is something that actually AOPA was able to lobby pretty hard to make sure that we got added to this bill. And this was in the third COVID bill, which was the one that created the stimulus package, that basically said the following, and I'll read this verbatim because it's important, that the Secretary of Veterans Affairs shall ensure that, to the extent practicable, veterans who are receiving or are eligible to receive prosthetic appliances are able to receive such an appliance. Sorry, I have the thing blocking my screen. I apologize. Such an appliance that the Secretary determines is needed from a non-Department of Veterans Affairs provider under contract with the Department during a public health emergency. So one of the challenges that we have really faced with the VA is a lot of pushback in especially local markets where the VA is trying to drive care into the VA clinics. And a lot of those clinics are either operating at minimal capacity right now or simply shut down and are not necessarily providing prosthetic and orthotic care. And we wanted to make sure that there was still a pathway for veterans to be able to receive care in the community if at all possible. So that language is actually built into the CARES Act language. Okay. So another, and I'm not going to spend a whole lot of time on this one because you'll see in a moment, it's unfortunately been suspended, but another initial option for some quick funding was through what was called the Accelerated and Advanced Payment Program. Now, this is a program that has always existed in the Medicare program that says that in cases of public emergency, Medicare has the ability to grant advanced payments to Part B providers and accelerated payments to Part A providers, where they will pay providers in advance of providing services for up to a period of 3 months with an extended period of time before those funds have to be paid back. This was an option that was very attractive to folks before the stimulus bills were passed, before the loan bills were passed, because it was a way for providers who suddenly had a shortage in cash flow to get some immediate cash flow injected into their businesses. They would have to pay it back, obviously. It would be offset against future claims, so it was kicking the can down the road, but it was still a way to address immediate cash flow issues and keep the doors open if necessary. Unfortunately, that program was suspended on April 26th. CMS came out with a statement that said due to the loan programs, due to the stimulus program, they did not feel that the advanced payment program was necessary any longer, and that the accelerated program, the Part A program, would be reevaluated based on payments that were already in place. So that program is no longer available for new applications. There is some question as to whether that is the only motive for suspending the program, but I don't want to get into too much speculation about what other reasons there may be. But for now, the advanced payment program is no longer available as an option, and the DME MACs are not accepting new applications for that program on a go-forward basis, at least for the immediate future. Okay, so what else has happened with COVID-19? Well, some of the things that have happened, we were supposed to start prior authorization, and that was supposed to start on May 11th. So that was supposed to start literally in about a week, just under a week, and California was going to be one of the initial states in which it was planned to be rolled out, with a nationwide rollout scheduled for October 8th of 2020. Now, it was very limited in scope. It only involved 6 HCPCS codes, all lower limb prosthetic codes, all high-dollar, high-technology prosthetic codes, several microprocessor knees, one microprocessor prosthetic foot, and then the L5980, which was a K3 functional level foot code. So, you know, the thing with prior authorization is if you polled the AOPA membership and probably the COPA membership as to whether prior authorization was a good thing or a bad thing, you'd be split right about down the middle. There are definitely some advantages to prior authorization. Folks that are currently dealing with it in the DME world like it tremendously. They feel it has been very beneficial. But at the end of the day, this is probably not the best time to start a brand new program where folks were going to have to learn a whole new way of doing business. So AOPA was not opposed to this pause. We do not know how long the pause will last. All we know is that CMS and the DME MACs have indicated that they will provide a minimum 60-day notice period before implementation takes place. So once the public health emergency ends and they elect to reinstate implementation, we'll have a minimum 60 days to kind of ramp up and get things into gear. So another question that people are asking a lot of information about is competitive bidding. We're scheduled for that to start in January of 2021. As of right now, The only thing that has been suspended from a competitive bidding standpoint is the inclusion of what are called non-invasive ventilators as a product category for competitive bidding in 2021. Obviously, ventilators are an access issue without competitive bidding, so it seems logical that they would suspend the inclusion of non-invasive ventilators fairly immediately from competitive bidding. We have not heard anything else as far as other product categories that are scheduled to go into effect in January of 2021, including off-the-shelf orthoses. One of the things that CMS will seriously have to consider is whether to rebid the competitive bidding program simply because the economics situation has changed, and it has changed permanently as a result of COVID. And whether or not they will acknowledge that and choose to, at a minimum, rebid the program is yet to be seen. Those are discussions that are being held on the back end. So one of the other things that Medicare has committed to doing during the public health emergency is really focusing on providers having the ability to take care of patients first and foremost. And to that end, and to their credit, they've essentially suspended every audit process that is out there right now for the duration of the public health emergency. This is very good news. This includes the Target Probe and Educate program, which was essentially your post-payment audit program that came into play at the DME MAC level. But then also all of the supplemental reviews, whether they're RACs, whether they're SMRCs, whether they are CERT reviews. Essentially, all audit activity, at least temporarily, has stopped, and it has stopped as of March 1st. So any claims that were in the audit process should have immediately been released and paid. So that's been proactive. It's been effective. And from our discussions with other provider groups, that has created a tremendous amount of relief for the provider community. The one exception to that is CMS does still reserve the right in cases where there is true suspicion of specific fraud and abuse. They reserve the right to continue to audit those claims. Okay, they've also relaxed a lot of the existing requirements, at least on physicians, and now actually on therapists, physical and occupational therapists, and any other provider who bills based on providing for service using CPT codes, which does not unfortunately include O&P providers, which bill for items using HCPCS code, but telehealth restrictions. So in the past, while telehealth was allowed under Medicare rules, it was a very restricted practice. It was limited to physicians, and there had to be very specific conditions in place to ensure the security of both the patient and the physician and any information that was transmitted through that telehealth visit. CMS has relaxed significantly the rules on telehealth. They are now allowing essentially audio-only telehealth visits, and they have really in the interest of protecting patients and limiting exposure to patients. They've really made a lot of exceptions for telehealth. We believe and we are confident that extends to any documentation that is obtained by physicians in support of claims that you are providing, as long as they are obtained through telehealth and under the telehealth waivers that have been put out there by CMS. They should be valid for documentation purposes. And again, telehealth is a subject that is of much discussion right now within AOPA, within the O&P Alliance, and we are working with CMS to get some additional clarification on the telehealth rules for that. So there are some specific waivers on replacements of orthotics and prosthetics that are directly related to the COVID-19 PHE, the public health emergency. However, those are fairly limited in that they are limited to replacement of orthoses and prostheses outside of useful lifetime restrictions, but only when it is specifically related to a COVID-19 scenario. So the example that we've been given multiple times is that, say, a patient has suspicion of being COVID-19 positive, they're being transported to the hospital for testing and for treatment, and somehow their device, whether it be their prosthesis or orthosis, is lost in the ambulance during transport. In that scenario, it could be replaced under this waiver provision, under this 1135 waiver, without a new order, without documentation to support the medical need for the replacement, and without useful lifetime restrictions in place. But you would have to bill that with a CR modifier on the claim to indicate that it was under an 1135 waiver, and again, very, very limited in scope to only those situations that can be directly tied to a COVID-19 scenario directly. Okay, so signature and proof of delivery requirements have been essentially waived during the public emergency because it is a situation where CMS is trying to fully limit exposure of patients. They are not requiring signatures on proof of deliveries any longer. If you can get it, great. If you can have the patient sign, if you can send something through a trackable delivery service, great. But if you cannot, for reasons due to COVID-19, if you cannot get that signature on that proof of delivery, just document it in your records, and it should not cause you to have audit problems either currently or down the road. Okay. There have been significant relaxation of processing requirements on appeals, and one of the things that has come out of this that AOPA and both ABC and BOC are not necessarily in favor of is there's been a relaxation of facility accreditation requirements as well as provider enrollment requirements. And the reason why that the different organizations do not necessarily feel that that is in the best interest of folks is because the blanket relaxation of these programs essentially opens the door for the unfortunate criminal elements that may be looking to take advantage of some of the relaxation of the regulations on this on these programs due to the COVID-19 situation, and get into a system that they would not otherwise be able to get into, and therefore commit some pretty heinous acts and take advantage of some pretty unfortunate situations. Okay, so how can you help AOPA? All right, so one of the things that we really need you to do is we really need you to keep us informed as to how things are going. If anybody's having problems accessing funds, accessing small business loans, we need to know about those so that we can translate and transmit that information to HHS and to CMS. Second thing is we need your pictures. We need to see O&P providers on the front lines providing patient care with PPE, patient protective or provider protective equipment. We need to tell the story to Congress that we are part of the frontline team of healthcare responders, of first responders, of people that are risking themselves to provide care to the community in this time of crisis. So those pictures tell 1,000 words. And third and finally, if there are any issues that are impacting your veteran population, we need to know about those so that we can communicate those with our contacts at the Veterans Administration and work proactively and collaboratively with those folks to make sure that access to care continues. All right, things for which you should be talking about, which you should be preparing. I know we're getting close to time here, so I want to be respectful of everybody's time. But we have asked members of Congress to support and include the first provision of the Medicare O&P Patient-Centered Care Act, which distinguishes definitively O&P from DME in the next COVID-19 response bill. While our agenda has shifted and we no longer expect to be able to promote the entire bill as we would have 6 to 8 weeks ago, one of the things that are going to help advance the mission of getting access to telehealth, being able to use telehealth in not only this emergency but in future emergencies, is to really get an arm's length separation from DME, to tell the story and to convince Congress to pass legislation that really recognizes O&P providers as patient care providers and not simply as commodity dealers. Okay. So another thing that we've done in an effort to try and get some people some immediate, much-needed financial relief is, as most of you know, there is a tremendous amount of cash that is tied up in the 5 to 6 year process of ALJ hearings. This is the final level of appeal. It's supposed to be done in 90 days, but because of a significant multi-year backlog, the administrative law judge dockets are backed up for multiple years right now. We've asked Seema Verma, the administrator of CMS, to consider a settlement option where Medicare would present the opportunity to settle all pending O&P ALJ claims for a percentage of the monies that are out there. That would clear the dockets. It would provide much needed cash to providers who have this money tied up. And it would help CMS and help HHS by clearing their dockets off and allowing for better efficiency in the appeals process. And finally, like Maynard said earlier in his opening remarks, if you have the opportunity to join us tomorrow for our virtual policy forum, we would have loved to have everybody come to DC and meet with your legislators. Obviously, that's not possible. So tomorrow from 1 p.m. to 2:30 p.m. Eastern, that I believe is 10 o'clock until 12:30 p.m. local time in California. Please come to our virtual policy forum. It's free. And then if you are so inclined, we also have a scheduled fundraiser for Tammy Duckworth, who has been one of our Senate champions for many years. She is a double amputee herself. And we've scheduled a virtual fundraiser for her to support her reelection campaign for the Senate, one of the Senate seats in Illinois for tomorrow afternoon as well. Okay, so questions. I think I can, let's see if I do have access to the chat window right now. So Jim Lawson actually from ABC chimed in and said that ABC will be posting a telehealth-focused Credcast podcast episode next week, so that's really good information. And then just some more information about the policy forum for tomorrow, the virtual policy forum. I don't see too many other questions that are good for the good of the group here. So with that, I will turn it back over to Maynard. I really appreciate your time. I know we did go through this very quickly. If folks have follow-up questions that they want to ask me offline, my email is on this last slide. Please feel free to contact me with any questions and send your stories to Justin Beeland at jbeeland@aopanet.org as well. So thank you very much.
Joe, thank you immensely for both preparing this presentation and presenting it. I know I'm always impressed with your depth of knowledge on each of these issues. I always learn something, so I hope all the attendees picked up a few things as well. I know you clarified a tremendous amount of information in each of these areas, so it was very helpful. Just a question from my standpoint on these 6 lower limb codes that have been delayed, where they were going to be implemented on a test in these 4 states in May, and then implemented in October. Has that entire schedule been scrapped?
So I wouldn't say that it's been scrapped, Maynard. Actually, they've just delayed it. So I've gone too far now. Sorry. So they will be implementing prior authorization at some point. It's just not going to happen in May and then October. So they don't have a new implementation date. What they've said is that they will give us a minimum of 60 days. And I expect that the time frame between the 4-state test and the full nationwide implementation, which basically was about 6 months, will still be in place. So let's say that they implement this in, and I'm just pulling a date out of the air. Let's say they implement it in September in the 4 states. Then I would expect that the full implementation will probably be March 2021.
Well, that was actually what I was trying to express. I had a little bit of an overreach there with being scrapped, but I meant delayed kind of indefinitely. So still we'll take that. Um, so are there any additional chats? I think they're probably the ones that you commented on already, Joe. So with that, I just want to thank all of our attendees. I hope, like me, you learned something from this presentation. We do want to thank you, Joe. I know you've got a very busy schedule, and you're highly engaged in all of the legislative issues that are going on. Uh, for those of you who are members, these webinars are a new feature from COPA, which we began a year ago, and we've conducted a number of these. We'll continue to provide them as an added benefit to members. We thank you for your membership. I know for me, it's kind of fun to click on the list of attendees and see so many familiar names or faces. So thanks to everyone who attended. It's good to kind of reconnect on Zoom or other platforms during these times. If you're not a member, I would encourage you to consider being a member of COPA. We collaborate with AOPA in very many ways. AOPA does things at a national level for our industry, and they're absolutely indispensable. I encourage you to be a member there, as well as COPA, because it's COPA that is the advocate for our industry at the state level. And AOPA really works with all of the state organizations to help us in our efforts. And some of you may know that COPA had teed up a Medicaid fee reform initiative that we were going to present in Sacramento on March 23rd, and they closed down the Capitol that week. And I'm not sure if they knew we were coming exactly, but it just happened to be that that's the time that they closed the Capitol for any visitors to the staff. So we weren't able to make that presentation, but we had, I think it was 18 different meetings set up with legislators or their staff to try to get an increase in the Medicaid, but Medi-Cal, of course, for all of us in California. The average for Medi-Cal across the country, or Medicaid across the country, is about 80% of the Medicare fee is what our reimbursement committee has concluded. In California, it's 51% on average of the Medicare fee. So it really leaves the most vulnerable patients at risk for the appropriate care, because practitioners have a very difficult time providing that service to the so many needed millions of people who need that care. I think there are 11 million people on Medi-Cal in California. So it's a very large percent of our population. So we are pivoting. We are reprioritizing our legislative initiative, and because the feedback we've gotten from legislators is that they're going to be implementing the same budget as last year. So everybody's really in a defense mode rather than being able to gain much. We're trying to defend what we have, but we are going to pivot to some other issues and hope to get some relief in other areas, and we'll bring that to you as it evolves. So with that, we will adjourn the event, but thanks to everybody who attended, and Joe, once again, thanks immensely to you. So we'll see everyone next time.
Take care, everyone. Thank you.
All right, so long.